All right, excellent. So we are going to get started. Welcome to everyone to another EBFA webinar. My name is Dr. Splichal. I am the CEO and founder of EBFA. I am also the CEO and founder of Naboso. So if you've ever seen any of the Naboso products, I'm affiliated with both of those companies. I'll do my introduction a little bit more in just a moment, but just in case if you're just logging in, we are going to be recording this. Once we do the actual content of the webinar or the educational part of it, then we will allow some time for questions. If you're listening to the recording, do not hesitate to reach out at any point and email me your questions or reach out to me on social. Okay, so I'm going to briefly introduce myself just in case if you're new to any webinars hosted by me or EBFA. I am a functional podiatrist and a human movement specialist. So I take a very integrated approach on how I look at the feet, how they influence movement. That integration of foot to core is something that I am very passionate about. I'm also very passionate about sensory stimulation and the neurosensory side of human movement. You can learn more about that through our educational courses, my book, and then of course the Naboso products. Having said all of that, today's topic is actually going to be a little bit more biomechanical based. And I know some people absolutely love biomechanics. So here is your chance to dive into some of our flat foot biomechanics. And then how do you use that understanding of the different foot type biomechanics to then shape their programming? Some of your clients or athletes programming, understand some of the injury risk, or it also can help you to understand some of the outcomes that you could see from the programming that you create. Now, why I wanted to do a webinar on this is because I actually see a lot of patients with some of these different flat feet that we're going to speak about. And they are coming to me after seeing physical therapy, maybe trying some stuff that they've seen online, and they're actually not getting results. They're hitting a wall, or there is this misunderstanding of the results that they can get from doing these exercises that maybe they've seen. And then they come to me because they know that I'm very much into integrated foot strengthening, and they possibly think that maybe I have an exercise that hasn't been introduced to them before. However, what I often share with them is that their unique flat foot type is one that is a little bit different and doesn't respond the same to foot exercises that they may be seeing on the internet or on social media. So I get that confusion, and I find myself explaining a lot of the same thing to these patients of, okay, you have a foot type that is a little bit different than a stereotypical flat foot, and you will not respond to exercises like a mild over pronation. So what we're going to do today is go into some of those different classifications. Some of this, if you're saying, where's the research on that classification, Dr. Emily? A lot of this is based off of my 12 years of experience and how I make my clinical decisions on if I just recommend exercises to a patient, or if I'm going to put them into an orthotic, what type of orthotic. A lot of that is based off of clinical experience. So I just want you to understand that as well. Obviously, I'm not making things up and kind of creating my own system, but I use a lot of these guidelines to shape my recommendations for patients. Okay. All right. So this is one of the biggest takeaways that I want, is not all flat feet are created equal. And if you're already saying, well, what is flat feet? What does that mean? I understand. I often say, I don't like that word. I never use that word flat feet because it doesn't really tell us anything about the feet. Just put little quotations around everywhere you see flat feet, okay? But one of the first takeaways is not all flat feet are created equal, and therefore, every collapsed foot, flat foot, overpronated, we'll just throw that out there. Every foot of that similarity are not created equal. And therefore, if you are using the same recommendations to any foot that may be flatter, then you are not going to see a equal response by every single one of those clients, patients, or athletes. Okay. And in fact, the term flat foot, remember I said I don't like that term. The term flat foot doesn't tell us anything about the functional impact of that foot, which is why I don't like that word. Maybe if you added some adjectives in front of it that we're going to go into, but if you just say, I have a client with flat feet, Dr. Emily, tell me what you would do. I don't know. I have so many questions I need to ask you, right? Because not all flat feet are created equal. Okay. So how do we start to consider the different types of flat feet? That is my goal through this webinar. Well, really, a lot of people are using this term flat feet when they should be perhaps using the word overpronation. But then again, not all flatter feet are overpronated, and we'll go into that as well. Now, many people will say, I have collapsed arches, but really what they should be referencing is a midfoot pronation or navicular drop, right? Also, if we say, and we look up at the first one that says not all flat feet, most people say flat feet when really they should be saying overpronation. What we could break that down even further is to say, well, is it rear foot or midfoot, right? So where is that pronation happening? Is it in the back of the foot? Is it more in the midfoot, which is this collapsed arch and this navicular drop, right? So let's start by defining pronation. Pronation, by definition, you would be saying that it is triplanar motion, which means that we are moving through the sagittal, frontal, and transverse plane all at the same time, and it takes at least 2 joints to pronate and supinate. So when it comes to the foot, your rear foot, which is the ankle and the subtalar joint, 2 joints, ankle and subtalar joint, rear foot, can pronate or does pronate, right? So the triplanar motion of the rear foot is happening between those 2 joints. Your midfoot, the way that we reference the medial midfoot, the midfoot can also pronate, and that is going to be through the 2 joints, talonavicular joint and subtalar joint. Okay, so those are the 2 joints of the midfoot that are pronating. Okay, so we got rear foot, we got midfoot. We need to make sure that we differentiate that if we are assessing the foot and creating programming for the foot. Okay, and we're going to go into a little bit more on what that looks like. And if this is all really new to you and you're like, I'm trying to visualize the talonavicular joint, the subtalar joint, then I encourage you to either look at some additional lectures that we have on either the EBFA Teachable platform or on the EBFA YouTube, or if you really want the most detailed explanation, then that would be through our Barefoot Training Specialist level 1 and then level 2. Okay, but here it's broken down for you. Here we have our rear foot pronation, which if you can see my arrow is right on the top here. And then we have under it, don't worry about the supination on the end, but obviously you pronate and you supinate. So it's just showing the opposite. But your rear foot pronation here, and then your midfoot pronation is here. So we got rear foot and we got midfoot. So if you're trying to break down the differences, you've got ankle and subtalar joint in your rear foot, you got talonavicular and subtalar in the midfoot. Let's go back a step. In your rear foot, you have your ankle. Step back. You got your ankle joint. Ankle joint does dorsiflexion, plantar flexion in the sagittal plane. However, your ankle joint does not just move in the sagittal plane, it also has a transverse plane motion. The way that we can appreciate that is I want you to take one hand, I'm going to show you on my ankle, and you're going to grab your malleoli. So I'm grabbing my malleoli of my right foot. My right thumb is on the inside. That's going to be my tibia. My right pointer finger is going to be on my fibula on the outside. So I got tibia and fibula. If you were to do this and shut your eyes, can you feel and appreciate that your tibia is sitting higher than your fibula? And at the same time, your eyes are shut. Can you appreciate that your tibia is sitting in front of your fibula? So the orientation of your ankle axis is actually oblique. If I were to bisect them, it would be oblique across the bottom of my foot. What that means is that when I move through my ankle, because the axis is oblique, this is my right axis, when I go to dorsiflex, I also abduct. When I plantar flex, I adduct. So it is dorsiflexion, abduction, plantar flexion, adduction. That's what we see right here, dorsiflexion, abduction. That's part of pronation, triplanar motion. And then the other part of our rear foot is your subtalar joint, and it is going to evert, okay? And we'll see this in pictures soon. So anytime you think about the rear foot in a pronated position, it is going to be a position of instability. It is going to be unlocked. So when we pronate, we unlock those joints. A unlocked ankle is one that is dorsiflexed and abducted. A unlocked subtalar joint is one that is everted. Okay. Now, similarly to your midfoot, the joint that we are referencing is going to be your talonavicular joint. So if I palpate down here to find the bones, the medial malleolus is your tibia. Go down a thumb, that's your talus. Go down a thumb, that's your navicular. So right there, if you even have a pen and you want to circle it, right? But right here, I'll kind of push, you can see that white area, right? That's my talonavicular joint. So when that part of my foot is going to drop down plantar flex, it adducts. Plantar flexion, adduction. Plantar flexion, adduction. You can see what's happening to my subtalar joint every time I do that. If I show you from behind, let me just make sure you can see it. Right? Do you see that? Eversion, eversion, right? Evert, plantar flex, adduct. Okay. If I do it from the front again, can you see that I evert, plantar flex, adduct, and then kind of, you see these creases in my ankle? That's the abduction of my ankle. Abduction is part of rear foot pronation. Okay, so we want to make sure that we are always breaking down the components of what pronation is. Okay, so it's triplanar. Try to break it down to the 3 planes. What is each plane doing? What is each joint doing? Remember, 2 joints are needed to pronate and supinate. So we got our rear foot, we got our midfoot. Okay, woo! Biomechanics 101. Yes. Okay. If that was a little bit like, whoa, is she speaking Greek? I would just say, let's listen to it again. Listen to it again, or definitely dive into some of our courses. Okay. Supination is going to be the opposite of all of this. Let's get into our classifications. Here we go. Okay. So you are presented with a client or an athlete who has no arch, right? Let's just keep it there, right? Flat feet if you want. From a distance, you see them, they come into your office. Okay. The first question that you want to be asking yourself to understand the function of that foot is it flexible? Is it rigid? That is going to start you down a tree, a flow tree of what you are going to do for that individual. okay? If it is flexible, that's the one that we're going to talk about first, right? Is it a flexible flat foot? Okay. The flexibility of a flat foot is dictated by the presentation of the foot, non-weight bearing and weight bearing. Okay. So you're going to have that client or the individual sitting in a chair, maybe they're on an examination table. So I'm on my exam table, right? And they're sitting there with their foot out, right? Here's my foot, non-weight bearing, okay? You're looking, you could look and just see, do they have an arch in that non-weight bearing position? Okay, here's the arch, okay. So if I were to stand up and I have an arch open chain, but then as soon as I stand up, I go boom. I have a flexible flat foot. Okay. You can also look at not just the side of the foot like this, but you can look at the weight bearing position like this. And you can just look for, right? The thing about the foot that is nice is that you have, the skin will tell you where you weight bear, right? So if you see how I have, it's a little bit redder here, you can see I clearly bear weight on the lateral side of my foot and then obviously in the heel. Look at my foot versus the picture, okay? Do you see how there is a callus and red skin right here on that picture? Okay, so the picture is showing non-weight bearing a flat foot position. If you start flat foot, open chain or non-weight bearing, well, of course you are going to be flat when you are weight bearing. You're not going to just suddenly be able to defy gravity when you're standing in gravity, right? So that is a really good way to create that first classification. Is it flexible? Is it rigid? Do you see a beautiful arch and the weight bearing pattern open chain is similar to what I showed you on my foot? Or is it like what we're seeing here on this picture? Okay, it's going to create that first decision, flexible versus rigid. Okay. Now, this leads to the second, which is going to be the most important part of this lecture, is if it's flexible, if you see an arch, non-weight bearing, and then they stand up and they go, right? The next thing that you have to ask yourself is this because their muscles are weak? Or is this because there's some sort of structural connective tissue issue? Right now, we'll just give one reason, which is a ligament laxity. Okay. Is it muscle weakness or is it ligament laxity? Okay. If it's muscle weakness, well, we know what to do. We strengthen the foot. We strengthen the intrinsics, the posterior tibialis, the core, and the glutes. And you should be able to, and research has shown that you can bring correction to a muscle weakness in the foot, right? Okay. If it's a ligament laxity, well, what do? We're going to go into that. Okay, we're going to go with the first one, which is going to be muscle weakness. This is going to be primarily observed in the rear foot. So you are going to see that subtalar joint falling a little bit inward to create that eversion. But I want you to appreciate that the talonavicular joint and the midfoot is not dropping and spilling down onto the floor. So this is more of that rear foot subtalar joint issue. Typically, it's going to be a little bit more mild. So you could say mild to moderate. Pronation, keep it in the rear foot. Okay. And then your goal is going to be exactly what we would think it would be, right? Intrinsic post-hip strengthening, right? There's also really, really good research that shows if you do 6 weeks of glute strengthening, you can correct a rear foot pronation 2 to 3 degrees. And a standard orthotic post is 2 to 3 degrees correction to the rear foot. So when I see what I know 6 to 8 weeks of foot to core strengthening can correct, the same as an orthotic, I'm not going to push that patient into an orthotic. I'm going to do the exercise because I want to maintain that baseline level of foot function. Okay, so right here is a good example of mild to moderate overpronation in the rear foot that we could use strengthening to stabilize that foot. Okay. Now, this is, if you look at this, you can appreciate, I know this is a forward perspective, it's not a backward perspective. It's not showing this major spilling out and bulging along the midfoot. So it's going to be a little bit more isolated in the rear foot. Okay. There's other things that are happening over here, right? But right now I just want you to see, okay, yes, that rear foot is a little bit unlocked in the rear foot, right? It's actually pushing a little bit closer towards moderate. But let's say anything that's suggestive of that, I would initially start with strength, foot strengthening. Okay. Now, the exercises that I would do just as a baseline to start for this individual are going to be teaching them how to find neutral. Now, when I teach a overpronated foot how to find neutral, my emphasis is on the influence the subtalar joint has on the tibia. Okay, now the influence that your subtalar joint has on the tibia is going to be that of the transverse plane. And I'm going to pull it pants up just a little bit, right? So as we evert our subtalar joint, you can see that there's this inward rotation of my tibia. So I want the individual, the patient, the client, to understand if they are going to reverse or correct the eversion, they need to externally rotate the tibia. If I take my hand and I externally rotate the tibia, you can see that I invert my subtalar joint and put it into a neutral position. That external rotation of the tibia continues all the way up into the hips. So I want that client or patient to create the correction all the way into their hips. They use the spiral to find neutral. Then, let's say they're brushing their teeth as an example, they would be doing that by finding neutral, external rotation of that tibia all the way from the hips. And then in that position is where I want them to hold themselves consciously to just know what that feels like. Okay. Now from here, we would then go into short foot, which is the exercise of pushing the toes down. Now, when I push my toes down, if you see my foot, you should be able to see that my arch actually lifts when I do short foot. And when our arch lifts, the subtalar joint inverts. So doing short foot is actually an exercise to strengthen the intrinsic inverters of the foot. And that is exactly what I would want to do in that mild to moderate rear foot pronation. Okay. Every time I teach short foot, I always want the feet to connect to the core. I have many videos of those on YouTube, so do check that out. Just search short foot and Dr. Emily, and that will come up. Okay. And then the last exercise is having a ball between the heel. When you lift and you have the ball between the heel, you are technically strengthening the posterior tibialis, which is a supinator or inverter of the rear foot. And when I'm on the top of my heel raise, can you see that I am tucking my heels in. So there's this inversion moment in my rear foot. So I'm teaching and training a full inversion of the subtalar joint. Okay, so we're doing a lot of the cueing and referencing towards the rear foot, which is based off of the research showing mild to moderate rear foot pronation will respond to exercise, intrinsic foot to core and glute strengthening. Okay. Again, this exercise, ball between the heel exercise, I have on YouTube. Just literally search ball between heel, Dr. Emily, it will come up. Okay. And you can even share that with your clients, the video. Okay. First classification of flat feet, flexible over pronation, that is mild to moderate. It's isolated to the rear foot and it will respond to exercise.
I didn't get that.
Ooh, sorry, scared me. The other type is going to be flexible over pronation that is structural. Okay, stop. That is structural. Now, the structural component is going to be ligament laxity. Okay, this could also be a component within the post-tib tendon, which means that perhaps if you have a mild to moderate overpronation of muscle weakness and you neglect and you keep pushing that foot, you can start to lengthen, degenerate, and tear your post-tib tendon, which is the one that is that supinator that we strengthen with the ball between the heel. And you essentially progress from one flat foot type to another flat foot type. Okay, so just because you have one doesn't mean you have one for the rest of your life. You could progress from one to the next. Now, the one that I actually want to focus on a little bit more is less that, and it's going to be the flexible flat foot or the flexible overpronation that is caused by ligament laxity, okay? Now, many people will actually say that my flat feet are genetic, right? I have my mom's feet, my dad's feet, and foot type in itself is not genetic. But what is genetic is the connective tissue integrity. This is very similar when someone says that they have bunions and that bunions are genetic. Bunions themselves are not genetic. It is the connective tissue integrity that is oftentimes the ligament laxity that is genetic, and then that predisposes that first ray to swing out and cause a bunion. Okay? So some classic signs of ligament laxity is going to be a midfoot collapse, navicular drop, and bunions, especially bunions in teenagers. If you see juvenile hallux valgus, which is bunions in teenagers, is essentially what it means. There is always ligament laxity present. You cannot blame bunions in a 14-year-old on shoes. I know that everyone is out to the shoe market and you cannot blame them for this. It is a ligament laxity of the medial column, and then it destabilizes that metacuneiform joint and that metatarsal swings out. Okay, so a ligament lax, flexible overpronated foot with a navicular drop cannot be corrected with exercise. I'll repeat that. Cannot be corrected with exercise. Now, does that mean don't do exercises? Don't do foot exercises? Doing foot exercises if you have ligament laxity is a waste of time? Absolutely not. That's not what I'm saying. What I am saying, though, is that if you have ligament laxity and causing a flexible overpronated foot with navicular drop, you cannot do foot exercises and think that the structure of the foot is going to change. Unfortunately, it doesn't work that way. Muscles cannot override connective tissue. If you had, as an example, I tore the ligaments in my ankle, in my knee, in my shoulder, the muscles that stabilize the shoulder or the knee or the ankle cannot replace the loss of ligament integrity. Can it bring some stability? Yes. But will you be just as stable as you were before those ligaments were injured or tore? No, it is impossible. So this is an example of a foot, a pronated foot, that now is much more in the midfoot. And I'm going to show you the other one. So can you see this? And then go back to this, that difference. I just want you to start to see the patterns and the differences of right here, all of this uncovering and dropping of the talonavicular joint that's pulling your posterior tibialis with it. So post-tib tendinitis and tendinosis and tendon injuries is very common in this foot. This could be a foot that has a tear in the spring ligament. The spring ligament is one of the most important ligaments in the foot that is ligament lax in many of this foot type. And it sits underneath the talus and the talar head, and it acts like a hammock. If that's torn or lengthened, boom, it's just going to drop, right? The mechanics just aren't there to maintain that arch. Okay, so this is going to be a ligament lax foot. This would be the example of a patient that would come into my office and say, but Dr. Emily, I've been doing short foot and the ball between the heel and all these other exercises. I'm strengthening my glutes and my foot still looks like this. And it hurts my knee and I get really tired when I stand for work. And help me, this is my left foot, right? What I will say to them then is no amount of strength is going to change the reality of that midfoot drop. So what you will have to use if you are symptomatic, right, or you're going to try to bring some sort of support to that foot, is going to be some sort of arch support or orthotic. Now, could you do this in a way that is friendlier to natural foot function? Sure, let's wear minimal shoes. So many of my patients, I actually saw a patient yesterday who had 0 shoes. And I said, keep the 0 shoes. Let's put a power step in the 0 shoes. And if you want to add in even more sensory, just put a Naboso activation on top of the power step in your 0 shoes. I'm happy. Right? We got a wide toe box. We got little cushion. Yes, I've added a little bit of mechanical support, but we're going to offset that with the Naboso texture on top. And we're creating this environment that is understanding your unique foot structure, but then trying to keep you as natural and minimal as possible, right? So we're kind of meeting in the middle there. The more progressed that foot is, and the more that ligament laxity and pronation becomes midfoot, rear foot, maybe it's a combination, maybe they're symptomatic, you might need custom orthotics. You might need a stiffer orthotic. As much as we don't want to go that way, that unique foot may require it. Okay. Other things that you can do if you don't want to go the orthotic way, totally respect it. I try to offer options for my patients. You could add a heel toe drop to your shoe. Technically, for every degree that you plantar flex the ankle, you invert the subtalar joint. So as we more and more plantar flex, you get more inversion of the subtalar joint. So if you have an overpronated foot and you go into some plantar flexion, do you pull that subtalar joint into a little bit more neutral position? Yeah, you do, right? Degree is relative to the individual. And then could we put an LA pad, an LA pad under the navicular? And an LA pad is like a scaphoid pad, and they'll just sit under the arch and it'll lift the arch slightly. So that combination of heel toe drop with a little pad under the navicular to lift it, Is that the environment that works for that ligament lax foot? Maybe. Okay. It's another option. Another option that you could do is what's called an ASO brace. An ASO brace is an ankle brace that laces up, and then it has two straps that essentially cross the front of the ankle. And when you cross those straps, you're essentially pulling that foot into supination, and you are locking the rear foot to essentially block what that ligament laxity is creating. In a truly ligament lax foot that is maybe having some symptoms, and the patient says, I'm going for a hike. I'm going for a hike. It's the one thing I love to do is hiking. Then I will say, I need you to put this ASO brace on when you hike, right? I have to lock your foot. Otherwise, if they go for a long hike and they're on the wobble and they have all of that instability perturbing the foot, I know it's good. But then that patient comes back to my office after that hike and says, my post-tib tendon is completely flared up. My plantar fasciitis is completely flared up, right? So I'm trying to navigate the balance of where I want them to be in a integrated natural foot function with the reality of their foot structure and then the activity that they're going to do. Okay, this is another offering for them. All right, so here we go. We've got a couple classifications already. First step, you see a foot, a flat foot, you're going to say, is it flexible? Is it rigid? If it's flexible, you go to the next decision, which is it a matter of muscle weakness or is it a matter of ligament laxity? Which one is it? Based off of which one it is, you will either recommend exercises or we recommend something that is supportive to the foot and exercises. Right? I want you to remember that I'm still saying do foot exercises. But for the ligament lax one, we might need to add in a little bit of that support. Okay, that's your first branch. Let's go back up to the top when you were deciding, is it flexible or is it rigid? For the rigid, this is going to be the one that non-weight bearing, it's a pancake, right? It's flat all the way across the room. You can see that that foot is flat when they're sitting on the table, okay? Which means when they stand up, that foot is not moving. It is going to be flat when they're standing. Now, here's the big difference. You can have a rigid, overpronated foot, and then you can have a rigid pancake. Now, a rigid pancake foot is not a formal term. You're not going to see that in a research study. That is something that I say and I call it just because it helps patients to understand. So is it rigid overpronation? Remember that part of overpronation is internal rotation of the tibia. So do we have this rigidity and they're stuck in a internal tibal rotation, internal tibial rotation, my goodness, tongue twister, internal tibial rotation position, or do they just not have an arch, right? What's that look like? Here we go. All right, so the example of a pancake foot would be the one on the bottom left, okay? That's my pancake, because if I look at the Achilles tendon and the subtalar joint, I'm not seeing a lot of eversion, right? Yeah, they don't got an arch, but I'm kind of like, I'm not that excited about what's happening from a transverse plane and up the chain, right? So this one, I would recommend things different than if you see, again, here, right? This one, we see this concavity, the subtalar joint, the total bulging. This one is totally adducted in that midfoot, right? And then here, similar, you can see that concavity. So we can see that there is a pronation or a eversion internal rotation element to these other feet up here. Okay, this one is more just no arch, right? It's like the arch drops straight down without everting and internally rotating. So that spiral influence up the chain, we don't see. Okay. Now, regardless, whichever foot it is, rigid overpronated, rigid pancake, the shape of the foot is not going to change that much. It's rigid. You're not going to get this dramatic change of that foot. Meaning, I'll explain to them and say, if any of you four are my patient and I'm going to give you exercises to do, your foot will never look like my foot. It's not possible. Okay. But does that mean you shouldn't do foot exercises? Absolutely not, right? But we're doing it for a different reason. We're doing it to improve your balance. We're doing it to connect your feet to your core, to maintain baseline function. Some of these, like this one up here, male or female, actually can't tell, but what I can tell is that they would be older. So I can just see that there's certain skin changes that I can just tell that that individual is going to be older in age. So my goal for that individual is going to be more fall reduction, right? So I need you to understand and connect to your digits. Your digits move. Can we get a little bit of connection, engagement, some of that short foot? Can I get some of the neurostimulation to your foot? But from an actual foot posture change, that's not the goal. Okay. Similar here. I'm going to do intrinsic strengthening. I could get your feet to core to connect. If you saw the full picture of this, this is probably called like a 30-year-old male, right? So lots of foot function we could bring back to it. Just again, you're not going to be changing that arch. So your goal is going to be foot strengthening, neurostimulation, foot awareness training, foot to core for the goal of function, not necessarily to change the actual foot posture. Then if they are experiencing symptoms and you were to use anything artificial, then the insert would have to be accommodative. Okay. For any of those that are listening, maybe some of you that are listening have a foot like this, maybe like this pancake foot here, right? And I hear it time and time again that they say, these are my feet. And I went to a podiatrist and they said, you have flat feet. You need custom orthotics because you have flat feet. And then they pay $500 or more for custom orthotics and they hurt. They hurt their feet more and they never wear them. I've had so many patients come to me with that exact foot type and say that exact same thing. So they go to someone else, try another pair of custom orthotics, still don't work. And they're just like, I thought that if you have flat feet, custom orthotics is what you need, right? And then I see them and I say, your foot type is rigid. Rigid feet, whether it's rigid overpronated or a rigid pancake, do not tolerate custom orthotics. They don't tolerate them. Don't waste your money on them, okay? You will not respond to them. So I would never write custom orthotics for this foot on the left, lower left. Okay. What you do want to do though, if they do use an insert, is something that is accommodative. There is what's called a plastizote insole. Plastizote is kind of like a memory foam. It's actually a trademarked material. It's kind of pinky color. Plastizote. You can find them on Amazon and they are accommodative. Okay. You could also theoretically do some that are custom, but they're accommodative. So they're prescribed very differently. They're molded differently. So I've done that for patients. Okay. So that's what I want you to start to think. So every single foot type should be doing exercises. Every single foot type should be doing the releasing and the neurostimulation, should be barefoot and getting that sensory input, connecting your feet to your core. But it's really, how do we navigate and understand which ones we can actually see a dramatic foot posture change from exercise. That's going to be flexible muscle weakness, which is more rear foot. As soon as that instability pops into the midfoot, you're talking about ligament laxity, post-tib tendon dysfunction, tear in the post-tib. It's a different animal. Still do exercises, but you're not going to change that foot posture. You may want to start thinking about some level of foot manipulation, heel toe drop, LA pad, custom orthotic, OTC arch support, right? ASO. And then for the rigid, still doing the exercises, right? Just make sure that's hit home. But we're looking at no change in foot posture. Could you get like 1 to 2 degrees in foot posture? Sure. Okay. But we're not talking a dramatic change. And then if any insole is used, it's got to be accommodative or they're not going to tolerate it. Okay. Now, what I want to do as we wrap up, if there's any questions, please do type those in. We have a discount for you so that you can dive into this even further. If you want to become BTS level 1 or 2, just use code webinar on ebfa.teachable.com. These are our online courses, and you will be able to dive deep into this and how you can start to navigate programming based off of foot type. Okay, we did do a webinar last month, which was on navicular drop. If you did not hear that, then definitely head to our YouTube and hear that one. That goes heavy into this midfoot pronation. So I'd even listen to that one and then listen to this again, and then you'll be able to create some connection. Okay. All right. So let me just see if there are any questions. Perfect. So we have a question that says, will a tennis ball work for the short foot exercise, or does it have to be a hemisphere or dome like the Naboso one? Absolutely. So you can use any foot release products. You could use tennis ball, lacrosse ball, a roller, the Neuro ball and the Neuro domes. Absolutely. The reason why I like the Neuro domes outside of that it's a Naboso product is that you can get both feet released at the exact same time. So oftentimes individuals just like that. It's a little bit easier to get it done, more efficient. Okay. Emily has a question. Is prolotherapy or stem cell injections possible or therapeutic solution to improve ligament laxity integrity? Awesome question. So actually, no. So you would think, based off of the theory of prolotherapy. So prolotherapy, which is like sugar water, it's dextrose, that is injected to create an inflammatory and a scarring response in ligaments. Most of that research and the benefit around prolotherapy for skeletal issues is more lumbar, pelvic, SI joints. You're in different joints, and the mechanics and the load and the force going through those ligaments are actually very different. In the foot and the ankles, specifically the midfoot and the talonavicular joint, the rotational force of the tibia into the talus is just so high that you can't bring sufficient integrity to those ligaments. In fact, a great demonstration of that, Emily, is that if someone tears their spring ligament that runs underneath the talar head, if let's say it's torn, you can't just go in there and suture or repair the tear to the ligament because it won't provide enough integrity. So what you do is you detach the post-tib tendon, wrap it around the joints, and then reattach it. So you're actually kind of weaving that tendon in and around the joints and then lifting it and then attaching the tendon higher. So that should just be maybe a little example of why just that ligament in itself isn't enough. We need a lot more strength into it. Okay. And usually if someone does have true midfoot ligament laxity and they have foot surgery to correct it, they have to fuse some of the joints. You have to do bony work. You can't just do soft tissue work and have sufficient results. Okay. Do the strategies explained here apply to pre-puberty 11-year-old female? Yes. So ligament laxity in children, this is where, or should hopefully help you understand how we navigate the appropriateness of orthotics in children. So pediatric flat foot is oftentimes ligament laxity, or I'm making the decision when I see a child as a patient. I am then assessing and seeing, is it more of a muscle weakness? We need to allow sufficient time for that arch to develop, or do they have ligament laxity and I'm trying to catch it early and get them into a stable position? I mean, if it is the ligament laxity, I am putting that child in an orthotic, and the orthotic that I use is called a UCBL, is what I would use. Great question. Do toe splay help flat feet? Toe spacers would be a way to reset and bring recovery to an overpronated foot. It's not going to reverse the foot. It's not going to strengthen the foot, but is it bringing stability and more of a natural alignment to the forefoot? Yes. What type of flat foot is the most common? Great question, Sean. I would say, honestly, it probably is the muscle weakness. It is the muscle weakness. However, for some reason this week, I've seen a bunch of the ligament laxity that thought that they just had muscle weakness. And then I tell them, I literally said these words to the patient, and I said, your foot type is not that rare, because I don't want a patient that has ligament laxity to think that they're this far outlier and they're kind of screwed, right? That they're like, oh my God, how did I end up with this foot, right? It's actually quite common, but it's common to me, to you, and to everyone who's kind of on that fitness training side. You'll see probably more of that mild overpronation that needs that muscle strengthening. But why I did this webinar is I want you to understand when you see the midfoot outlier, and then use this information to guide them a little bit different than that muscle strength one. Okay, great. I've had clients with midfoot pronation, but no pain of any kind. How is that possible? Totally possible. Totally possible. If there is ligament laxity, is there ligament laxity if there is no pain or discomfort? Absolutely. And can that affect their gait, having ligament laxity? Yes. Okay. So if you have ligament laxity, does not mean that you're going to have foot pain, right? I often tell people, I'm like, you've defied the odds. You rode under the radar, right? You lucked out, right? Now, let's say if someone with ligament laxity starts running marathons, they might start getting pain, right? So it has to do with the level of stress that they're placing that foot under. And if that stress just hasn't hit a fatigue point, maybe they've gotten away with it, right? Or I had one, again, recently who's, I think they're about 45, something like that. And they're like, oh, but I was an athlete. How did I like play basketball and do this and this and this? And I had this foot, right? And I essentially say, you know, it sucks getting old, right? Essentially what it is just, it's an accumulation of stress based off of that individual's life choices of activities. So, all right. So Carmen says, you talked about heel drop. What about negative heel shoes like earth shoes? Not sure if they're negative, but if they are, I probably would not recommend a negative heel drop, like an earth shoe, to someone with ligament laxity and that midfoot pronation, because they're essentially going to drop down. As we drop down, you can start to strain the post-tib tendon, which is really good. And kind of this bonus information is, if you have ligament laxity and midfoot pronation and you are training barefoot and you are stretching your calves barefoot, you have to make sure that that client holds their foot in a neutral position. They've got to rotate and lift that arch, or you need to post them while they do their calf stretch. And this is going to be my next webinar next month, is little things that you can do to make sure that you're getting the best foot position during something like a calf stretch, right? You calf stretch, we need a post to you. So I would make sure that I would not do an earth shoe in someone with the ligament laxity and that midfoot pronation, because you're just going to pull into that post tib tendon. Another question, when people have the condition in one foot only, should they do the same exercises on both? Yeah, absolutely. One thing that I will add to that, Lenise, that's a really good point, is that when we pronate or we have ligament laxity in the midfoot, that shortens that leg. So if I have overpronation or midfoot drop in my left leg more than my right leg, I've essentially shortened my left leg more than my right leg. So now my pelvis is going to be oblique. We need to address that, right? So think of the, you could argue if it's functional or structural, limb length discrepancy in the pelvic obliquity that is associated with an asymmetrical pronation. Whether that pronation is muscular or ligament lax, we still need to think of what it's doing to the leg length and to the pelvis. Okay. Another question. Ooh, we got so many great questions. Oh my God, a lot of questions. I'll try to answer these questions quickly. And if you have to drop off, I totally respect it. These are being recorded. If a client has bad knees and not able to have knee replacements and is bow-legged, will any changes to the feet make a difference? Not necessarily, because bow-legged, which is genu varum, is different. That is structural. That is not necessarily related to the feet. Now, could you make sure that they have good foot mobility and like good internal, external rotation of the tibia and good stabilization all the way into the glutes to protect the knee? Absolutely, right? But I just want you to know that genu varum, bow-legged, is a structural hip to knee alignment issue that is not necessarily related to the feet. How long does it typically take for an individual foot to respond to exercises? I give it 6 to 8 weeks before I assess. So 6 to 8 weeks consistently doing something, and then we reassess. Your assessment could be based off of you measuring calcaneal eversion. It could be you assessing navicular position, right? So you could actually use something that is quantifiable. You could take pictures, but I would do that every 6 to 8 weeks. Does PTDD, post-tib tendon dysfunction, require surgery? Will exercise help delay or prevent the need for surgery? So PTTD is based off of grades. So you have grade 1, 2, 3, 4. Grade 1 is just post-tib tendinitis. Grade 2 is getting into a little bit more tendinosis, but you don't have true degeneration or tearing into the tendon. Grade 3, you have a tear in the tendon and you're starting to pronate into the midfoot. Grade 4, you are pronated in the midfoot, have a tear, and are pronating into the ankle. So depending on the grade, you would do surgery. Depending on the grade, 1 or 2, yes to exercise to delay or prevent the need for surgery, grade 1 or 2. As soon as you're 3 or 4, they usually have to be in orthotics and in an ASO to really lock the foot. Still, you would do exercises, but they have to go back into an ASO and orthotics. Good question. Sounds like a webinar I need to do. Okay. What about the second toe crossing over the others of one foot and the big toe lifting up on the other? This happens a lot with my clients. You could see that more in a ligament lax foot. I did do a bunion webinar that you might want to check out. And I suppose that I could do a second MPJ webinar. Okay. I have a client who has a naturally high rigid arch, but also has rear foot instability, uses AFOs. She has muscle weakness through the medial line and anterior tibialis, barely able to dorsiflex her ankle. She's been told that she needs an orthotic for her arch. What would be the case for the orthotic? So that individual, and they use an AFO, O, which is for the ankle, and they have an element of foot drop. Also in here, it says that she has neuropathy. So that's actually describing what is called a neurological foot. Again, just for the sake of time, I need to kind of run through it. And Emily, I need to do a webinar on that. But high arches, cavus feet are actually can be classified as a neurological foot, and the whole foot pulls in and the arch and the digits lift, and then it becomes very, very rigid, and then they can't move the anterior muscles, and they essentially have foot drop. That all kind of goes in it. The orthotic, because that was your question, is most likely accommodative. I'm guessing it's going to be made out of plastizo of some sort. Okay, I'm going to do two more questions. You guys have awesome questions, but then we are going to wrap up. Andrea asked something about high arches. I clearly need to do a webinar on that. Emily, you have so many great questions. Let's see. Here, Sherry asks, this will be the last one. Can chronically tight calves, which causes limited ankle mobility, cause dysfunction of the post-tib weakness, and cause some of this flat foot, this navicular shift? Yes? Yes. So one of the causes of overpronation is a limited ankle dorsiflexion, and they compensate around the ankle by unlocking the rear foot and going around the subtalar joint and the ankle. So yes, part of flat foot reconstruction. So if someone has surgery on their flat foot, part of the surgery is you essentially lengthen the Achilles tendon, because tight ankles is very deforming. It's a very strong deforming force on overpronation. So absolutely, if you want to prevent overpronation in your clients, you got to focus on ankle mobility, make sure that they're doing sufficient ankle releasing. If they have a bony block, we want to make sure that we're addressing that. You want to recenter the talus if they have a bony block. So there's a lot of stuff that we want to make sure that we're addressing on that ankle, so that they don't keep compensating by overpronating, and then year after year after year, that compensation becomes rigid, and then it looks like one of the rigid overpronated feet that I showed, right? Okay. All right. You guys had such awesome questions. I guess this is a topic that you guys were curious about. So that's great. Thank you guys all so much for tuning in, for listening to the recording, for hanging out, for all of the questions. Do check out our educational courses. Stay tuned next month. What we're going to start doing is every single month this year, we're going to do a free educational webinar. So stay tuned for those. Make sure you follow EBFA, myself on Instagram, and Naboso. Have an amazing night. Thank you again, or day, depending where in the world you are. Thank you, and be well.